All right, guys. So we'll talk. Good afternoon, everybody. We're gonna talk about valves. Last time we talked about the aortic valve. Today we're gonna talk about mitral valve and tricuspid valves. Mitral valve. When we talk about mitral valve, there are two things that we have to discuss. First, mitral valve regurgitation and mitral valve stenosis. Regurgitation of mitral valve are 4 degrees. Okay, mild, mild to moderate, moderate to severe, and severe, which is 1+, 2+, 3+, and 4+. In terms of management of mitral valve regurgitation, the treatment of choice is either mitral valve repair or mitral valve clip. So mitral valve repair or mitral valve clip. And there's another option, which is mitral valve replacement, but you don't really entertain doing anything to the mitral valve unless you're severe. You really do not entertain doing anything for the valve unless you are severe. Even before start having symptoms, there's data suggesting that going after the mitral valve, repairing the mitral valve early on in life is going to prevent congestive heart failure and is going to prevent cardiomyopathy. Now, the indications for mitral valve repair or replacement, if you have ejection fraction below 60% and you have severe, if you have severe with symptoms, shortness of breath, or if you have severe in somebody who's younger than 60 years of age, that you expect that down the road, the regurgitation of the mitral valve might affect the heart function and create congestive heart failure. Okay, anything below severe, you just get an echocardiogram once a year or something like that until you find out that the mitral valve becomes severe. In that case, ejection fraction below 60%, you have to refer your patient to surgery. Ejection fraction above 60% associated with symptoms, age below 60. In that case, you have to refer your patient for surgical intervention or some kind of intervention. The differences in treating mitral valve, if you have functional mitral valve regurgitation, i.e. you have regurgitation below, you have severe regurgitation in the setting of ejection fraction below 50%, and your surgical risk is increased, in that case, mitral valve clip is reasonable. But if your surgical risk is acceptable, your ejection fraction above 50%, then replacement or repair is good. And always remember that the repair of the valve is much, much better than replacement. Why? Because you have these chordae and you have these papillary muscles attached to the valve system. The whole apparatus is going to help the heart function better than cutting everything and replacing the valve itself. Okay, always repair is much better than replacement. Okay, do you have any questions about mitral valve regurgitation? Okay, all right, so just remember EF 60% or less, severe mitral valve, EF 50% or less, in the setting of severe mitral valve regurgitation, clip, and repair is always much better than replacement. Bad luck if you're going to do mechanical mitral valve, because you're going to be stuck with Coumadin for the rest of your life. INR should be around 3.
I had a question.
Go ahead.
How can you optimize them medically if you're opting to not go for surgery?
There's some data about ACE inhibitors.
Okay.
But guideline-directed medical therapy for cardiomyopathy. Nick, anything going on? Download, what's going on? Okay, so there's really nothing you can do besides guideline-directed medical therapy, which is if your ejection fraction below 50%, you have to do ASR or ARNI, which is Entresto, and beta blockers and stuff like that. But nothing you can do magically to improve the function of the valve, unfortunately. All right, now mitral valve stenosis, severe mitral valve stenosis okay? Uh, Associated with symptoms, then you have to proceed with intervention, which is surgical intervention and repairing the valve, or I'm sorry, replacing the valve. If your gradient across the valve more than 10, the mean gradient above 10 millimeters of mercury, if you have associated exercise stress associated pulmonary hypertension, the setting of mitral valve stenosis, in that case, surgical intervention is needed. So anything below severe mitral valve stenosis becomes complicated, and surgery usually is not indicated. Unless you're pulmonary hypertension with exercise or something like that, your gradient goes high with exercise. In that case, you have to think about it. But severe mitral valve stenosis, always, you should just remember that, mitral valve stenosis is kind of protective for the heart. So the heart can tolerate stenosis, mitral valve stenosis better than aortic valve stenosis. But in general, if you have severe mitral valve stenosis, you have to send your patient for surgical intervention. Below severe, moderate, or mild, you have to wait, right? And there is a certain score that you go with, which is measuring how much calcifications you have in the valve. If you have less calcification, then balloon valvuloplasty can be done. But hardly can see mitral valve stenosis without a lot of calcifications, and usually surgical intervention is needed. Any questions about mitral valve stenosis? Can anyone give me the definition of valvular AFib? What is the definition of valvular AFib?
AFib in the presence of mitral prolapse?
No.
Or...
Dude, you've been with me in clinic for a while. Okay, so a valvular mitral valve valvular AFib, if you have mechanical valve, aortic or mitral, or tricuspid or pulmonic, which is unlikely, or you have atrial fibrillation in the setting of severe MS, mitral stenosis. That's called valvular AFib. Okay, so why are we concerned about valvular AFib? Because you have to put your patient on Coumadin, and the NOACs are not indicated in these kind of patients. NOACs are indicated for AFib, for non-valvular AFib, which is no mechanical valve and no severe mitral valve stenosis. Did you guys get this point? Okay, NOACs you can't use in mechanical valves. NOACs, Eliquis, Xarelto, Pradaxa, you cannot use in severe mitral valve stenosis and AFib. Just, I want to bring that up so for you to know. Even some cardiologists really don't know that. Now, we talk about the stenosis, and there's always association between mitral valve stenosis and pulmonary hypertension. And sometimes, some patients, we send them for exercise testing to see the pulmonary hypertension and the increase in gradient. And if the increase in gradient was significant, in that case, your patient should be sent for surgery. The other valve, which is a tricuspid valve, actually there has been a lot written about tricuspid valve. It's usually called the forgotten valve. And if you have severe tricuspid valve regurgitation in the setting of acceptable right ventricular function, surgery is needed, either repair or replacement. Okay, severe tricuspid regurgitation in the setting of reasonably functioning right ventricle, in that case, surgery is needed. Now, almost always, if you're above the age of 80, 85, you're going to have certain degree of tricuspid regurgitation, and these kind of patients you really need to treat medically. And usually the reason for tricuspid regurgitation is pulmonary hypertension from the diastolic heart failure, from the COPD, from pulmonary hypertension, you name it. In that case, you don't really repair the valve and you leave the valve alone. Okay, so if somebody who's 60 years of age, severe tricuspid regurgitation because patient has some kind of radiation, breast radiation because of breast surgery, wherever, some kind of tricuspid valve prolapse, in that case, you should not ignore the tricuspid valve. But somebody who's 85 years of age had screwed up right ventricle, screwed up lungs, and by default the tricuspid valve is gonna have issues because of the increased pressure on the right ventricle. In that case, you just leave it alone. Okay, so that's something you have to keep in mind. And tricuspid valve stenosis, what do you think about tricuspid valve stenosis? What's something very unique about tricuspid valve stenosis etiology wise? How about carcinoid? Right? There is some association between carcinoid and tricuspid valve stenosis. Very rare, is really rare, and treatment obviously is surgical intervention if it's severe. Okay, so these are the valves. Any questions about these two valves? Now, so I'm just going to touch up quickly on terminology for devices. Okay, you really need to know that. So when it comes to devices, always remember that the first letter, P, okay, the first letter is P, which is the chamber paced. The second letter is the chamber sensed. The third letter is response to sensing. Response to sensing. Okay. Now, the fourth number, which is R, which is rate response, and we'll talk about each one. Okay. Now, if I give you D, 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 what does that mean? Can somebody go over it? So it's dual chamber device. It can pace in atrium and ventricle. It can sense in the atrium and the ventricle. So if there's any atrial activity, it will inhibit pacing. If there's no atrial activity, it will provoke pacing. So the last letter, which is response to pacing, it's dual as well. So it's dual chamber device, dual sensing, and dual response, D, D, D. And if you add R to that, it's going to have rate response. Do we have to turn rate response on every patient? What do you think, Shay? I can't hear you though. Why not? That's very smart. Yes. So we don't need to do that unless you have sinus node dysfunction. So if you have somebody with complete heart block, the sinus node is good, so their sinus node should be enough. If you have somebody sinus node dysfunction because of history of AFib, ablation, whatever, then you have to turn it on. Devices are pretty smart. They have accelerometers and they have temperature sensing, and they will sense changes in temperature or changes in impedance, movement upstairs, whatever, and based on algorithm, it will give you extra heartbeats based on certain programming. And the temperature changes, we're not talking about going from 37 degrees to 38 degrees or from 96 to 97. No. We're talking about 0.01 changes. And that's good enough to alert the device that, hey, your patient is in action, so you have to get rate response. Fair? That's called rate response. Now, how about if I do VVI? R. Matt, what's that? First letter.
Paced in the ventricle. That one's
Right.
easy.
So it's single chamber device.
Yeah, single chamber, paced and sensed in the right ventricle. And then VVIR. Oh, so it inhibits in response to.
So it inhibits. So basically, if there's ventricular activity, it will inhibit. Right? So it's always on, but it will inhibit. So it doesn't have dual function, it just inhibits. And the R is rate response. So that's called single chamber device, VVIR. Okay. How about this? Who can take on this? Grady, you think you can do that? Grady probably on the beach.
Eve is pretty
Yeah.
quiet over there.
Yeah, the ventricular paced, ventricular sensed. Oh, no, I don't see your face anymore. Let's see here. I can't see the sheet
So
anymore.
first chamber.
Oh, there we go.
Okay.
No, ventricular paced, dual
right.
sensed,
Dual
and
it trigger or inhibits
it triggers.
or inhibits, right?
Yeah, because it's dual.
Okay, and rate response.
Rate response.
We see this with the Micra AV. You know the Micra AV, the single chamber device, Micra AV?
Yes.
So it has some kind of mechanism to check the, to respond to the sound of the tricuspid valve closure. So it only paces in the ventricle. It can sense what's going on in the atrium via sensing the sound coming from the tricuspid valve from the tricuspid valve closure, and in terms of response to sensing, it can inhibit or trigger.
That's how it senses, is through the sound.
Exactly right.
That's pretty cool.
It's a very sophisticated device, and it can has the rate response activity. So that's the Micra AV, VDDR. Okay, let me do another one. And that's for you, Grady. How about this one? And that's important because I can tell you this is why we have to be, this is why I'm doing this. VOO, what does that mean?
So ventricular sensed?
Ventricular, no.
Paced, I'm sorry, ventricular paced.
Ventricular pace doesn't sense.
Mm-hmm.
And because it doesn't sense, there is no response to sense.
There is no response or inhibition.
So that's single chamber device MRI mode. Whoever works with me in the clinic, this is how we do it. Right, Matt? Right, Matt? Yeah. Okay. Now, I'm going to do another one. How about this one? DOO.
So it'll be dual paced with no response,
Sensing.
no sensing and no response.
And because no response to sensing, there's O, so 0. D00. That's dual chamber device response to when we do MRI. This is how I program that. So I usually just program that 80 here, single chamber, 80 here, 80 beats per minute for dual chamber devices. Okay, so you really don't want the device to respond to anything and just pace during MRI. That's what we do it. You know, do you have to do it this way? This is the way I do it, but that's the way we try to do that. So always remember this kind of terminology, you know, because you may just you know, work on patient that you have to understand, and sometimes by just looking at the device itself, you can figure out what kind of what you have to do. There's a lot of other sophisticated stuff such as AAI in Medtronic / DDDR, when they just switch between what we call the MVP, which is minimal ventricular pacing, to minimize ventricular pacing, because you know the more we pace the ventricle, the more likelihood that you're going to have pacemaker mediated cardiomyopathy. And this is why whoever works with me in the clinic, I always try to do BiV pacemakers for patients to, if I think they are dependent, to prevent RV pacing mediated cardiomyopathy. If you add the FP lead, you will never have RV mediated cardiomyopathy, or RV pacing mediated cardiomyopathy, or pacemaker mediated cardiomyopathy. Okay.